Everyone is talking about digital front door, online forms, NHS app, e-consult. Aim is to get patients in faster to speed things up. But is it working? The numbers tell a different story. The waiting lists have jumped from 4.5 million to 7.8 million, whereas the waiting times have soared from 8 weeks to 13 weeks. And that is great, right? But here is things nobody is saying out loud. If you let more people in but do not change how the decisions get made on the other side, you haven't solved anything. You have just moved the queue. It used to be one big visible room. Now it is 6 invisible ones. A queue for form review, a queue for callbacks, a queue for referral vetting, and a queue for diagnostic. And there may be many such queues. Now you get the picture. The waiting room didn't just disappear. It went all digital, became invisible. So what is actually going wrong? I think the real bottleneck is not access. It is what I call decision bandwidth. Can the system produce enough safe, timely, and pathway correct decisions to keep up with the demand? And when you break down, there are really 3 things that gets squeezed. First is the cognitive load. The clinicians interpreting complex symptoms, atypical presentations, risk factors, overlapping diseases, overlapping patterns, multimorbidities, red flags, new guidelines, all under time pressure. And second, operational load. Ordering the right tests, picking the right pathway, and getting the documentation right so that the referral does not bounce. And the third is the governance load. Making sure every decision is evidence-based, auditable, and consistent. Not just down to who happens to be on the shift that day. When all 3 gets maxed out, you get things that we all recognize: delayed decisions, defensive referrals, patient bouncing around the system, incomplete workup. Sounds familiar? And the number back this up. Physicians are saying this out loud, that the demand is pulling away from supply. We are looking at a gap of around 100,000 full-time equivalent in most projections. Millions on the waiting list, and some months more than a quarter of A&E patient waiting over more than 4 hours. We can't recruit our way out of this. We had to scale decision making, not just headcount. Now let us discuss a little bit about the hospital decision making, what I call as the hospital brain. Now here is what we find exciting. The NHS already has got brilliant decision making engine. It is just locked inside the hospital. Think about it, that every breast clinic, every GI services, every dermatology team, they know exactly who is urgent, who can wait, and the investigations to order first, what referrals will get bounced and why. That knowledge lives in pathways, escalation criteria, and outcome data. But the GP and the community team, they rarely see any of that in real time. It is buried in PDFs, intranet, and let's be honest, in hundreds of senior consultants who have been doing this for 20 years or so. So the question remains is, what if we take the hospital brain and make it available at the GP front door? So now I am proposing this concept of multi-agent smart layer. This is what we have exactly built. We call it as a multi-agent smart layer that sits between the patient and the GP, powered by actual hospital pathway logics. So instead of a patient filling a generic form and waiting for days for somebody to look at it, they are routed to a specialty agent. For example, a breast symptoms can go to a breast agent, a rectal bleeding goes to a lower GI agent, skin lesion go to a dermatology agent, and each agent collects hundreds of data points, symptoms, risk factors, medications, family history, lifestyle, imaging, and not to forget what is the best practices, guidelines, resources available, etc. and produces a structured risk assessment with clear recommended pathway with no black box, auditable, transparent logic behind each decisions, each recommended pathway. Not vague like go and see your GP, go to your nearest ED, A&E, etc. In an actual clinical decision with next steps. Cases safe for primary care can remain in primary care with clear guidance and safety netting, with some input for the primary care team as to how to manage them and where is the threshold. And the cases that need secondary care can go straight to the right clinic with pre-referral workup already completed. No bounce, no wasted time slot. So now let us talk a little bit about the real case. I'll give an example of a couple of real cases, at least one from a real life example of a breast pathway. A woman in her 50s comes in with irreversible nipple inversion. She has got previous history of breast cancer. Agents pick that up immediately, high risk, fast track to breast specialists. Another patient, long-standing skin dimpling, stable for years, but she does have prior history of breast diseases. So the agent flags it as intermediate, needing investigations, but not all with same urgency. Then you have got a young woman in her early 30s with cyclical breast pain with no red flags at all. The agent identifies that confidently as low risk, manageable in the community, and her GP. Or maybe a breast care nurse can call for counseling, support, and reassurance. That is not a agent asking 3 questions and telling you to call 111 or giving generic advice that you should be seeing your GP within 2 weeks' time. This is hospital grade clinical reasoning, evidence based, data driven at the point of first contact, and that is what brings a coordinated path across all the care level, whether it is community care level, primary care, secondary care, emergency care, or any other care system that exists in connecting these care levels. And it does not stop at triage. Once the agent has assessed the patient, the same intelligence flows through the entire pathway: prioritization by urgency, waiting list, optimizations, etc. So the goal is the right patient with right slot, right time. Load balancing across the facilities, so one clinic does not drown while other one has spare capacity. So we can get a clear picture that the clean handover flows into diagnostics clinics with results and with a clear next action every time, auditable with a transparent basis for each decisions made. So there is no question of black box. Instead of 6 disconnected queues we spoke earlier, now you can get a coordinated, data-driven, continuous flow of patients and data. Now let's talk about the patient experience. The beautiful thing is that the patient does not see any of the complexities from their side. It is very simple. They call the GP, they get a link on their phone. When I say they call the GP, the GP receptionist identifies, yes, this is a breast lump, this is a GI issue. So they send the appropriate link to their phone. They answer the questions in their own words, in their own time, on the sofa, not waiting in a crowded, chaotic waiting room. The clinician then sees the structured summary with risk scores and recommendations, not pages of unstructured text. The patient gets an appointment that actually matches their need, and then afterwards they get tailored information and support, not a leaflet and a "we will write to you in due course of time," etc. That's what it feels like. So what this multi-agent smart layer can deliver? In practical terms, what this actually means is that the way traditionally we are bound by constraints with the mounting pressure, that will no longer exist in this new system. More decisions per day, because clinicians are not spending 60-70% of the time gathering the information. The agent has already done that, and that translates to fewer unnecessary referrals flooding the secondary care, fewer serious cases slipping through the net, shorter journey for the patient, less duplication, less "tell us your story again," and few handoffs. And with smarter use of what we have got so far, the clinics are filled with the right patient capacity shared across the system, not piling up in one place. So coming to the new system that can be created with the help of this bigger front door, with smarter brain behind it. We can, by bringing this hospital grade decision making support into GP practices and community setting, we can turn fragmented queues into coordinated pathways. Remember, as I said earlier, access alone is not efficiency. Data-driven decisions lead to better efficiency. And that is what we are building. If you are interested in what this could look like in your trust or ICB, then let's talk. Drop us a text. Here, the link is in the description. Thank you very much. If you have any questions or comment, please feel free to use the comment box.